This is the money slide. All of this advocating, trials, all result in what's new since 2004 that extends survival for advanced or metastatic prostate cancer patients. That's the list. Now, breast cancer, I would have to do it on 3 slides. Prostate cancer, I'm just yippee happy that I've got a slide with multiple boxes. So they're color-coded. Your orange on the top are your chemos. And the first one was 1996, mitoxantrone. 1996, the next time we had anything was 2004. That was the first chemotherapy. The same chemotherapy that's used in breast cancer that was approved years before we got our hands on there. We have sipuleucel T, which is the first vaccine in class. We have 3 or 4 of the greens, which are all your oral drugs. Now, you know, we use generics like abiraterone. You guys know them with their trade names, Zytiga, enzalutamide, Xtandi. Empower yourself there. Because when you go to see different specialists, they use different terms themselves. So most NCI centers, we're defaulting to the generics because that's what we're yelled at to do. But in your everyday life and you're looking at the bottle, maybe it's generic, but your instruction sheet might come with trade names. Now everybody's confused. So if you're taking care of a loved one or it's you yourself and you have 10 other medicines that you have to take, it's hard to keep track. So empower yourself there. You have radium, which is a radio pharmaceutical drug. You have relugolix, which I think I heard somebody mention earlier. That's an oral drug, an ADT. You've got lutetium or Pluvicto. And then you've got the 4 reds. Now let me just ask you, those are all PARP inhibitors. Of this room, who knows or understands those drugs out there that all of them look very familiar? Raise your hand. A few. To really, really empower yourself, get familiar. Because it's time to talk about this particular thing. You ask questions like, I see you recommended abiraterone. What about the other 3 drugs? Are they also available? Now, talk about stepping up your game. You don't really have to know the data, the Kaplan-Meier curves, and all the details. You just need to know there are 3 other drugs. Now, if you think advocacy doesn't matter, I'm going to pause here to say that in my great state of Michigan, one of the struggles we had as being one of the 7 states that didn't have oral chemotherapy was every time I prescribed one of those pills in the green boxes, I wasn't assured that my patient would not have a copay or anything else so that he could actually get the treatment I would like. Now, House Bill 4071 has been approved, and it's now going to go into effect in 2025, which ensures it's an oral chemotherapy parity law, that if your insurance plan says, okay, we'll cover the chemo IV, you will also get the same benefit oral. That took 15 years of us going to Lansing, working with various organizations, just like what you're going to do tomorrow. It matters. I hardly believe it. We used to go to Lansing with our advocates, with our signs. Sometimes you didn't even get airtime. You had 1 minute to have this discussion. 1 minute, you were shut down. So you have to know in your heart that what you're doing is going to be very, very impactful, even if it takes a long time. But I'm living proof to tell you, after 15 years, that's all I got to say. So I also want to say that we were talking about disparity. So if you strip away, as Chuck Ryan was saying, you strip away the access and this and that, all of those drugs, when there was an intentional look between how white men and black men did in terms of survival, they were the same. The same. And actually one of them, sipuleucel T, fared better, meaning better overall survival in black men. So if we could get to the right treatment and the person's got the right treatment, we have then already achieved equity in care. A lot of the research that you're talking about and hearing still revolves around the androgen receptor. Yeah, that's a pretty horrible looking slide. There's no quiz, no test, but just like in breast cancer where we can't get away from the estrogen receptor, we're still highly fixated on the androgen receptor. So you hear terms like it's an AR inhibitor, it's an AR antagonist. So that's what that means. You're just touching that receptor in all the different ways. And just know that tons of drugs that are being developed now in the pipeline, in clinical trials, target that in some way, shape, or form. So if you say to your doc, well, what is this drug, doc? How does this work? Does it hit the androgen receptor pathway? Hello, you guys are already experts more than, wait, what? What are you asking me? You don't have to know what goes to where, but you have to know what the drug is doing that also will help you live longer with advanced disease. Now, this is a slide we often like to show in national meetings. And if you look at this, you go, I have no idea what this slide says, except that the take-home message is if that you are newly diagnosed or even with recurrent disease, like you got diagnosed 10 years ago and oh crud, now the thing is in my bones, and you're just starting your hormone treatment, you need a friend to go with it, and that's either a pill or a pill with chemo. And why does that matter? You knowing this right now today is because your survival is better. Look at the stuff on the right. If you're just a one-drug wonder, you live X amount. If you're a single versus a double or a triple, it's a 15+ months improvement in your overall survival. Not, I'm kicking the can down the road, nothing. It's if you got one shot and your twin got a shot in a pill or a shot of pill and chemo, this twin will live longer by 15+ months. Now, is that a missed opportunity if we don't get you to have that? Sure it is. How are you going to know that if your doc doesn't bring it up? You won't. You can empower yourself knowing that there's something that has literally changed the metastatic landscape. And it's all in those green boxes plus the chemo when needed. So what happens a lot is we get into sort of like doctor speak, and you'll have these numbers like, well, the hazard ratio showed us that. First of all, you lost me at the word hazard, and I don't know why you're talking math and or stats to me, because I'm sitting here, I just need to know the plan and why you're doing it and what are some of the side effects. So really important to not get bogged down. Say, doc, I don't need to know hazard ratios, Kaplan-Meier curves. That's for you to know. What's the benefit to me as a patient? How do I get this drug and why? And why do I say that? Because right now, half the men in the country are not getting the treatment intensified. Half. There's a treatment plan that helps you living longer by 15+ months, and half of the men in this country don't get the pill or plus chemo. Can you advocate for that? You bet. So if your neighbor says, oh, I got newly diagnosed, I have bone metastases, you say, so you're on a shot and a pill? You're on a shot, a pill, and some chemo? What? Yeah. So you can then advocate on a whole different level, much more detailed in a way. And how we think about this, if you say, oh, yes, well, I'm your doctor, and I'm fully aware that there's 2 or 3 does better than 1, but I've decided that our practice just can't deal with this whole prescribing for oral drugs, so we're just not doing it. Sometimes those decisions are harsh, but that's what happens. You've got things like, well, because of your terrible type 1 diabetes, well, wait a minute, doc, my type 1 diabetes I lived with for 60 years, as one of the gentlemen said here. I'm perfectly okay. Why are you treating me like I'm not okay? You can advocate yourself there that way too. You could say, hold up. My diabetes is in great control. Give it to me. Tell me so that I myself can make the decision. And then again, the chemotherapy coverage. So again, 4071, it was a win. The other way we think about this is where the data lies. So just so you know, terms like disease burden, disease stage, presentation, disease risk. We use that all the time in commonplace language between our colleagues and ourselves, but we tend to then have that leak over sloppily to conversations with you guys. So Again, risk in terms of the PSA for Him Act versus risk, what it means for you making the treatment selection factor, they all mean different things. So if you want to get even more deep, these are some of the reasons that we say you need 3 versus 2 versus 1. So another term of empowerment, and you walking in also that this is the data and where I think about how it's important for you to know where you stand is, if you are a man that presents with high volume, in this case sort of defined by more than 4 spots on your bone scan, or a visceral, which is like liver and lung, and you just were presented like you went to the ER and poof, you got diagnosed, without doing anything, your median overall survival is 3 years. It's very low. That tells you right there, give me the kitchen sink, doc. Because if you were a person that showed up with, well, I got 2 lymph nodes and maybe 1 bone metastasis, and I had my prostate out 10 years ago, look at that median overall survival, 8 years. So maybe you make smarter decisions about yourself because you say, well, listen, you not touching me, I'll be okay for 8 years. Maybe I don't want to go through everything you're suggesting I should go through because my quality of life means more. Can we pace this out? Those are things that's important for all of you to know to make good treatment decisions for yourself. These are factors that we use all the time. And this is that data I was telling you about, how half the group doesn't know, but it also depends, based again on our research as well, of who's your primary person. So if your urologist is maintaining your treatment plan in your metastatic disease, those folks, compared to oncologists, were both really low. Their uptake on the 2nd or 3rd drug is very low. So you should then say, is there a medical oncologist maybe that I would like to talk about or with for other strategies? So you yourself can advocate for that. And it's not a US-based problem. When we look globally, it's kind of a problem everywhere in the world, that people have this information, but no matter where you are, Switzerland or Greece or Spain, men are still not getting optimally treated. So our voices actually need to go beyond the United States to really make sure. We use this scale for deciding chemo fitness. And I want to put that as there, because sometimes you hear those words, well, my doctor doesn't think I'm chemo fit. So those are some of those parameters, like have I fallen in the last 3 months? Am I getting a treatment for GU cancers? Yeah, for prostate you are. Do I have more than 1 or 2 comorbidities? When we in the clinic start adding this up, we go, gosh, you're frail and your chemo fit score is becoming low. Maybe 3 is not going to be better than 2 because you might have more side effects. So those are questions you can ask. Hey, doc, so you're not giving me chemo. Why not? What's the treatment? What's the thinking? Not saying you're questioning the judgment. You just want to know what's the thought process as to the why. Because if you know, then you're on that, you're on the train for like, this is the plan. I know what I'm doing. There are 2 drugs that are in more advanced. One is docetaxel, which I'm sure many of you have heard about. The other one is cabazitaxel. Both are still in active use today. But if you compare that to breast cancer, where they have a list of 20, we don't. We have 3. So it's not that chemo is evil. Many of you choose to, let's kick the chemo thing down the road, which is okay. But just know that chemo is very active, and it does also extend survival. So when appropriate, it's appropriate. I come back to this slide again to show you that the new stuff is in the red. So you got the one in 2019, you've got the other in 2020, 2023. So brand new, basically. But to get those drugs, you have to know what your genetic marker is. So that's a catch, isn't it? Not everyone is eligible. So how do you know you're eligible if your doctor doesn't check? Well, yeah, that's a good point. Now, we've just asked, well, how do you know if you're genetically predisposed? I don't know. How do you know if you don't know to ask so that you could check so that you know? So those 4 things, get it off your slide, because then you don't know. So now you know. If you're going to have one of those 4 as an advanced patient, you might be eligible for those drugs, but you don't know unless your doctor checks. And this is something that, as a general oncologist and a subspecialty oncologist, is really hard to keep up. Now, I bring this up not so that you all can squint and go, what the heck is she showing? But that first bullet is all about prostate cancer. Hey, if you're diagnosed with intermediate, unfavorable, high, very high, locally advanced or metastatic, you should get genetic testing, germline testing, inherited panel testing. What did your mom and your dad give you for your DNA blueprint? Okay? Why does it have to be that complicated? There are other risk factors. So what to do is just lump it. If you have prostate cancer, go get a genetic test. Now, I've just seen some recent data that hasn't been published yet, but how are we doing in the United States with this? And the answer is not great. The uptake is about 30% and way, way lower if you're a black man or any other categories other than white. And why is that important, this method? Why is it important whether I know I'm BRCA or not? This nice figure, this scientific figure, just tells you it's all about your DNA, and if it's going to need to be repaired or not repaired, those drugs prey upon that weakness in your cell. So if you don't know you have this as a way to the cell, then you are missing an opportunity, and that opportunity sits untouched in your treatment plan. And it's important because there are more drugs coming in this path to try to leverage an already dysfunctional DNA repair mechanism, as in, wasn't working great to begin with, so let me just make sure that cancer dies by putting an extra pill. And these are the drugs, but when you look at the fine line, they're for people who have the genetic mutation. So I come back again and ask you, how do you know if you are possibly gonna get the 4 drugs in those 4 red boxes if you don't know that you're eligible? Doesn't matter what race, where you're coming from, the geography, a test is a test. Now you could say, the problem is my insurance won't cover it. Good news, for every patient in here, there is a national registry, and I always make this plug for Drs. Channing Paller and Heather Chang, prostatecancerpromise.org. It's free. You go on their website. It's a few clicks, because I've done it with my patients multiple times. They send you a kit, you do a saliva swab, you get your answer. No charge, no reporting anywhere, done. You get genetic counselors if you're positive. prostatecancerpromise.org. There's no excuse of worrying that your insurance company is going to find out, you're not going to get your life insurance. This is one tool with no cost, because if you get charged for a regular test, it sometimes could be $3,000 to $4,000 a test. So you want to know. You absolutely want to know. The other part of testing, so you could also test your prostate cancer, because they get a mind of their own and they hijack your already not great DNA. If you know that you are what is status called MSI high, there's an actual immunotherapy that doesn't care what cancer you have, that all of a sudden gets expanded on your menu. So who has heard of pembrolizumab or Keytruda? Right. For every person here, everyone should know, because if you're that 3% of men who have prostate cancer, who have that drug is yet another medication on your treatment list. 3% is not zero, folks. And I personally have 2 where their PSAs were literally 2,000 down to 1. So when it works, it works. Of course, we can't cure people, which is why we're all still at this game. But do you want to know that if that's you? Yes. How do you know that's you? You have to test. So ask for that type of testing. And the word on immunotherapy so far has not been favorable, except if you've got that MSI high status. So lots of trials ongoing. So, you get bogged down here. And immunotherapy is great in every cancer. I treat bladder cancer, I treat kidney cancer, thumbs up. Prostate cancer, not there. So I just want to put that out there. People have heard of CAR T. Who has heard of CAR T treatment? Okay, CAR T is well known in leukemia, myeloma, lymphoma. It's now making its way to solid cancers. There are trials around the country for CAR T, which basically is like a bone marrow transplant. You get a high dose of chemo, and then you get your T cells that have been jiggered to recognize the cancer. So you're just empowering yourself in this session for all the new drugs that are possibly out there. And of course, PSMA. That's been the longest story on the planet. And I think last year it was more of an access issue, et cetera. But really, it's I've got a thing on a prostate cell, I can image it, and now there's a drug. There are 3 different imaging agents. So if your insurance company, like mine, often declines, figure out if it's a problem of the tracer. Oh, we only covered this one, but not this one. Go back on appeal. Have your doctor appeal, not to appeal, but find out, is it a tracer problem? You've got 3 choices now. In addition, this is what we see. So when you see the glowy bits compared to a bone scan, it just shows you where that cancer is, and it's more. You don't even need to have widespread disease. It's now, oh no, my PSA is going up. Wait a minute, I had radiation 5 years ago. Where is it coming from? Everyone's getting a PET scan. Oh, look, that glowy thing on the right side of the pelvic bone that did not show up on the CAT scan shows that you might have some cancer there. Empowering yourself with the plan with new diagnostics. Collaborations everywhere. So even if you have one drug, there's now many coming. So all those clinical trials are completing or have completed. And that's going to be for after you've had one of these oral drugs before chemo, that change is coming, probably sooner than later. We still don't forget about radium. So that is a drug that Marie Curie discovered many years ago. That's still active, and a lot of radiation docs are not talking about it. But if it's appropriate, because you only have stuff in your bones, that might be something you want to know. And these are some of the other targets that are in play, but I put that right there. If you go on clinicaltrials.gov, there are over 1,000 clinical trials for you to enroll in. Advocate for yourself and for one another to move more boxes on that slide. I want to get to this lecture where I have 2 slides, and I have multiple boxes on both slides, because that just would make everyone's life easier. But that can only happen through trial enrollment. That can only happen if you participate. And you could participate in a registry, you could participate in a therapeutic trial, just participate. I think that's my last slide. So thank you very much. I'm happy to take some questions. Yes? Yeah, that PSMA, Pluvicto, yep. So people needed to have one oral drug, one chemo, and then that medication. So the change is it's one oral drug, and then Pluvicto is probably the next step. So that's probably going to be in the upcoming months, a change. Yeah, great question. Other questions? Yes?
I recently had a PSMA scan. Oh, geez, okay. that actually did find what we thought was some cancer in a lymph node. But prior to being able to get that authorized by my insurance, I had to go through a bone scan and a CAT scan and maybe even another scan before they would even consider it. And I'm trying to figure out exactly what the logic is behind that.
No logic. They want to just spend money. They want to spend money. You know, they're trying to avoid paying. So what they do is say, well, your standard scans, if it shows it, you don't need a PET scan. Meanwhile, I'm like, what happens is if we suspect it and we order it, it's not a fishing expedition, so you're going to end up paying for all 3. But from a patient level, that's 3 tests. That's 3 times, you know, you're getting exposed to even a tiny bit of radiation. But why do unnecessary tests? Maybe we can convince ZERO to take that on as the next mission. I don't know. I'm sure there's lots to do. But that's a frequent challenge in my practice, too. Mm-hmm. Yeah. Oh. One more. Oh, okay. Sorry, guys. Whoever.
Hi, just an observation and a comment. We've been speaking about health disparities, and when I look at some of those words, I have a doctorate. I can't pronounce some of those words.
Yeah.
So can you imagine a person who's just been told they have been diagnosed with prostate cancer and exploring treatments? They won't have a clue
Yep.
as to what these words are. And also, doctors don't like to be outsmarted by their patients. So if I were to come up with one of these big words with my doctor, he would ask me, what do I know? And I'll say, well, I heard about it at a conference. And so we've learned that, sometimes doctors make judgment when the patient comes before them. Mm-hmm. They make judgments as to what the patient knows. But some of these big words, I did research going through my diagnosis, and I had to go to Google to read some of these research papers. But I'm not the average person.
Yeah.
But the average person from the street, they accept what the doctor tells them, go along with whatever the treatment the doctor gives them, which may not be the best treatment for that person. But it's just very challenging, with the way the treatment is going. And I was saying to the doctor here, how do you persuade black men to go for clinical trials based on the history that everyone knows about?
Yep. First of all wonderful points, I think, from what you just shared. There's a few things. If you are going to a doc that's going to get offended or felt judged, you're going to the wrong doctor, okay? Because the good ones out there, they shouldn't be offended. In fact, they should be happy that you're empowering yourself with knowledge. That's one. Number two, if I pretend, for example, that my car is making a funny noise and I would know anything what my mechanic is saying, should be even the worry. That's why you have lectures like this and events like this, because all you have to do is, even if you're like, I don't know anything, you take one of my slides, you take a picture and you go, I was at this conference, tell me about this. In our own symposiums that I've done for the last 13 years, I used to give tearaways. So it'd be like, listen, you like this, you just tear off the little thing and you take it with you. When PET scans were just starting, everyone was so confused about PET scans, it just asked different things like, I was at this conference, here, can you answer some of this? So you gotta get a person that is your team leader that you're comfortable with, that you can share that. Number two, no one expects you guys to know the vernacular at all, because we barely know it. None of it makes any sense. I know there's companies that actually name these things, but as a person who developed drugs, these were drugs like ABC 123 many years ago. So if you're looking at all these names, I remember it when it was not even a name. But that should not worry you. What you want to know is, how am I going to advocate for myself so that you as the patient, understand the plan and the why? And if that person can explain it, great. If that person cannot, you got to think twice and figure out if you're in the right place. I have the luxury of practicing in Detroit, where I treat the homeless and the CEO in one clinic. Oh, it's a lot of fun. But their access to care is so different that it has made me realize you got to meet the folks where they're at. And that means either they have every resource in the book because they're here after an executive physical, because they work for a car company, or they literally stumbled in because they got found on the ground being drunk and they're in the ER and, oh my gosh, that back pain is a PSA of 5,000. Wherever they're at, you got to meet them and share with them the why and then the how. But ZERO, for example, has done such a tremendous job of helping you get there. But what I'm hoping that this lecture showed today is just, there are a ton of resources for you as the patient that's in patient language that sometimes we default to, but it's there. So empower yourselves.